Today PACES session is on consultation, and the faculty that we have here is Dr. Tapas Banerjee, sir. He is a senior consultant physician and academic in charge of Department of Internal Medicine at Manipal Hospital, Kolkata. So you can start. Thank you.
Yeah. So, good evening, everyone. It gives me immense pleasure to welcome you all to this scientific session on consultation skills for MRCP PACES with a focused discussion on station 2 and 5 as I've been assigned. So arguably the most challenging yet most rewarding station is this PACES examination is station 2 and 5. And unlike the physical examination stations, consultation stations test who you are as a doctor and not just what you know. They assess your ability to communicate clearly, think ethically, structure information logically, and most importantly, connect with the patients as human beings. Station 2 primarily evaluates information gathering, explaining diagnosis and management, shared decision making, addressing the patient's concerns and expectations. Station 5 also goes a step further, deeper, and tests ethical reasoning, handling difficult conversations, breaking bad news, managing uncertainty, risk, and emotions. I will go to the detail of this breakup and the skills that are being tested in station 2 and 5. And in these stations, clinical knowledge alone is not enough. Many well-prepared candidates fail, not due to the lack of knowledge or lack of known facts, but due to poor structure, inadequate empathy, or inability to align their approach with the patient's agenda. Now, today's session aims to demystify these stations. We will focus on a clear consultation framework that works consistently, examiners' expectations and making domains, common pitfalls and how to avoid them, realistic case-based role-play scenario. I'll put 1, 2, or maybe 3 if the time permits, otherwise 1 or 2 role-playing cases, and we'll discuss with the communication strategies that score marks. Remember, PACES examination are not looking only for perfection. They are looking for safety, clarity, professionalism, empathy, and a structural patient-centered approach. I think I'm clear up to this point. If you can demonstrate that you as a doctor, they would trust with their own family members, you will pass the examination. The station. By the end of this lecture, my goal is that you walk away feeling confident, more structured, and more prepared to face any consultation scenarios. Now, the basic objectives of station, as I have already mentioned, to evaluate a patient presenting with certain symptoms, focused, formulate diagnosis, differential diagnosis, explain investigation, management plan, and relevant concern. Station 2 and 5 hold most important stake in PACES and evaluation. Are you able to see the slides?
Yes, sir.
Excuse me?
Sir. Yes, sir.
Okay. So station 2 and 5 hold most important stake in PACES evaluation as it carries the highest marks. And this is, just a minute, 56 out of 168 reserved for the station. All 7 assessment skills of PACES are included in these stations. Now, there are 2 20-minute brief clinical consultations, that is in station 2, 20, stations 5, 20. And you receive information on both the cases outside prior to the start of the examination. We all know. You are given a short paragraph for each of the clinical scenarios, which sets the scene, that is a referral letter or a situation facing the senior house officer in the medical assessment unit. Then you have 5 minutes to read them, formulate, and allow within this allotted time, you try to make notes, and rough paper will be provided for this. You are allowed to take your rough notes into the examination station, but at the end of the examination, you have to hand over to the examiner. So each of the cases takes 20 minutes in total, and you have 15 minutes to take a focus history and carry out a focus examination, which can be carried out at the same time to define the clinical problem, explain the diagnosis, plan to the patient to answer any questions and directly address their concerns. The patient or the surrogate have been briefed to ask basically 2 or 3 specific questions. You will get a warning from one of the examiner after 13 minutes, and the last 5 minutes of the session are for discussion with the examiners. One examiner will ask you to report to any abnormal physical signs elicited and your diagnosis or differential diagnosis and your plan of management. If not already clear from the discussion with the patient, then you can formulate according to the differential diagnosis and also try to corroborate with the patient's clinical findings. Now, in the 5 minutes prior to the start of the session, read the scenario very carefully outside the room. Identify key information present in the scene setting summary and make notes of this. Use the time allotted to build up a differential diagnosis, as I have already said. And it is important to remember to keep an open mind and not to get drawn into following only the differential diagnosis you have considered after reading the summary. So once you see the patient or the surrogate physically, maybe you have to change the order of your differential diagnosis at times. So be prepared with that. And the information on the sheet will also report background medical condition like hypertension or diabetes mellitus, and these also need to be addressed even though they may not be the primary presenting complaint. It is worth having a mental checklist of all areas that need to be covered, including the patient's concern. Now, these are the 7 skills that are being tested. So, number one is the physical examination, then identifying physical signs, clinical communication, formulating differential diagnosis, clinical judgment, managing patient's concern, and maintaining patient's welfare. These are the 7 skills that are being tested. For example, during physical examination, demonstrate correct, thorough, systematic, and focused in station 2 and 5, particularly appropriate, fluent technique of physical examination. Identify physical signs correctly and not physical signs that are not being there. Do not try to find out those physical signs. Maybe out of, say, there are 10 physical signs and you are being able to identify 8. That is suffice. So maybe you may not be able to identify all the 10 signs, but if you identify one sign that is not there, it is basically discredit. Now, regarding clinical communications, definitely this is one of the most important thing that the examiner notes during this particular station. Elicit clinical history relevant to the patient's complaint in a systematic, thorough, fluent, and professional manner. Each point is very important. And explain relevant clinical information in an accurate, clear, structured, comprehensive, fluent, and professional manner. Create differential diagnosis for a patient that is relevant to the patient. Clinical judgment is what is tested maximum in this point of time, and select appropriate investigation or treatment for a patient that the candidate has personally clinically assessed. Apply clinical knowledge, including knowledge of law and ethics, to the case. So maybe there is something that is against the ethical issues. You should not go beyond that. Managing patient's concern is one of the most important thing. Acknowledge the patient's concern or the relative's concern. Listen to the patient carefully or the relative and confirm their understanding of the matter under discussion and demonstrate maximum empathy to the patient. Now, treat a patient or relative respectfully and sensitively, which is probably one of the most important thing that is important in this type of examination, and the manner that ensures their comfort, safety, and dignity, which you have to maintain throughout the period of this examination. Now, physical examination, as I have already mentioned, practice it daily with one of your colleague or friend. The more you practice, definitely, the more natural you will become in performing examination. Identifying physical signs, again, I have mentioned, which I want to reiterate once again. Not finding physical signs that are not present is of paramount importance. And you need to have a PACES-oriented mind. Popular cases should be rehearsed again and again and again with proper preparation. This skill is easy to pass. Remember, if you could not identify physical signs, your diagnosis and differential diagnosis will not be correct, and that will affect the other skills. So try to find out maximum physical signs present there. Communication, as I've already mentioned, and you all know that this particular communication skill is one of the most important thing that is given maximum stress, and you need to practice how to be confident and at the same time show your empathy. This is a very important, as this skill sometimes can link to skill for managing patients' concern. Creating a sensible differential diagnosis for a patient that the candidate has personally clinically assessed is of paramount importance. After you finish your examination, put all the positive findings together to give your provisional diagnosis and sensible differentials. So you should prepare differentials while you are studying. This is a very crucial advice. However, you should tailor your differentials according to your case in the examination hall. If you mention differentials which are not relevant, you may lose marks. Clinical judgment is one of the most important thing that is being assessed in this membership examination. Select or negotiate a sensible and appropriate management plan for the patient. Select appropriate investigation, appropriate treatment for the patient. Apply your clinical knowledge, including knowledge of law and ethics. Practice the management plan for each diagnosis before the exam. If you are not sure of the diagnosis, your investigation and management plan should cover your differentials rather than particularly pinpointing one particular diagnosis which you are doubtful. So you can always consult your consultant in normal circumstances and other specialists. And remember, you are not treating the patient alone. Consider whether you need to stop the patient from driving, which is very important, and don't forget to provide safety instruction during your examination, and properly you should instruct the patient what are the safety measures. Managing patient's concern is one of the most important thing. Listen to the patient, and you should try to be a good listener, or the relatives, confirm their understanding of the matter under discussion and demonstrate empathy. Time management is critical for this skill. Sometimes what happens, the candidate continue to take history or do physical examination, and hence they do not have enough time left to address patient's concern. This is fatal mistake, because that actually going to lose your time, and you should always give sufficient time to address the patient's concern. Maintaining patient welfare is of paramount importance. Treat the patient or relative respectfully, sensitively, and in a manner that ensures their comfort to the maximum, their safety, and their dignity. Candidates who cause patients significant emotional and physical discomfort or suggest a management plan that would jeopardize patient safety would be given an unsatisfactory at this skill. So ensure comfort, safety, and dignity. Be respectful and sensitive enough. Now, the structured history-taking format is presenting history present history is like the history of present illness. The key questions you have to ask relevant to the case, then relevant history in the past, any surgical history, medical history, drug history, family history, and also personal occupational history, high-risk behavioral history, like exposure to sexual transmitted disease, which should be dealt with maximum sensitivity. Then his social history, system-specific history sometimes is required, and their concerns. This is how you prepare for the station 2 and 5. I'm not going to the very integrate detail complex things, but lots of practice against the clock in small groups teaching sessions helps a lot. Communication skills need to be developed as part of the preparation. They will be tested throughout the station 2 and 5 with the need for focused history taking, explanation of the differential diagnosis. Candidates should think about how to get most information out of the patient in the limited time available. And early open questions can bring out a lot of information quickly and allow more focused questions to narrow things down. Time yourself during examination so that you get a feel for the speed of the required, and it is important to have a checklist in your head, perhaps on the notes you are taking into the scenario. It also essential to explain in plain English the differential diagnosis, investigation plan, and treatment to the patient, and then to answer their questions and concern. This means avoiding medical terminology, jargons, and abbreviations. It should be in layman's terms. Get feedback from the colleagues on your skills during the practice. This is all about the practice before the exam. Now, I have prepared 3 case scenarios. The scenario 1 is 28-year-old female with type 1 diabetes. If you have any question or query, you can, otherwise I will go to the case scenario. Is it okay to move on to the case scenario?
Yes, sir.
Yes, sir.
Okay. So the case number 1 is a young lady, 80-year-old female, type 1 diabetes, diagnosed since she was age 12. So it is almost 16 years. She is being stamped as type 1 diabetes, and all the necessary investigations at that point of time was done, including the antibody test. So she is a known case. And now she is presenting to you with a history of numbness and burning sensation of both the lower limbs, and the symptoms are gradually progressive. Now, within the limited time period, how do you interrogate the patient? So, focus history. How it started, that is the onset. How long it is there? The lady is saying it is for the last 6 months. Then progression, it is progressive. Sensory versus motor symptoms, she is only having history-wise only numbness and tingling sensation, but there are no motor symptoms. She is not having any autonomic features in the form of bladder bowel involvement or history suggestive of postural hypotension. Now, glycemic control is one thing that is very important in this patient, because during management also you have to give maximum stress on control of the blood sugar throughout the year or throughout the month. Now, this is assessed by several questions, but within this limited period, ask at least what is your HbA1c level and how is your fasting or PP blood sugar, or sometimes do you have any hypoglycemia? Do you feel dizzy? So these are the things that will help you to understand how is the blood sugar control. Is it very swinging type of blood sugar? Sometimes it is 60, 70 or 90, like that. Sometimes it is 300. Then you can at least understand that probably the patient is having very high HbA1c level if it is not there. Other diabetic complications like in the form of retinopathy, or if it is possible to inquire other things like any histories suggestive of any kidney involvement or not, or any sort of other things like does he feel any sort of dizziness, or does he have any history in the past suggestive of any neurodeficit other than this tingling numbness. Then history of smoking, drug history, history of alcohol intake is definitely important. The red flags in these cases are maybe one is asymmetrical involvement. Usually we know that diabetes with such type of involvement is usually symmetrical, as the diagnosis points towards the peripheral nerve involvement. Then if it is asymmetrical, definitely it is atypical involvement, and which may happen in diabetes, but this is not the usual thing. Then if there is any motor weakness, so ask the patient whether she is having difficulty while standing from sitting posture, or squatting from standing posture, or having any difficulty of combing or buttoning, unbuttoning, that is suggestive of motor involvement, proximal and also distal. If it is not there, it is okay, but if it is there, you should try to make sure that it is sensory motor involvement rather than only sensory involvement. Then involvement of the sphincters, like bladder involvement, bowel involvement is there. The bladder involvement, usually there is history of incontinence, but bladder involvement may be constipation, maybe intermittent diarrhea. So these are the red flag sign that you should try to elicit. Other than this, any systemic symptoms other than the motor weakness or sphincteric involvement. So this is probably the young lady, type 1 diabetes, and history of numbness of both the lower limbs, particularly the feet, which is gradually progressive for the last 6 months to 9 months, is the diagnosis diabetic peripheral polyneuropathy, predominantly sensory. That much we can say from the history. Then comes examination. On examination, within this limited period of time, you always examine fine touch by cotton, starting from the distal end, then gradually ascending up, then motor system involvement by examining the lower limb first and upper limb. Gradually, you have to also examine the by other than cotton, you have to examine pin prick sensation by for crude touch sensation, and also examine the reflexes superficial and also deep reflexes, particularly the ankle jerks, the deep tendon knee jerk, and in the upper limbs also the biceps and the triceps. So these are the things that you should look for. Definitely will also assess the power, motor power, if there is any loss of power or weakness in the lower or the upper limbs, to assess whether it is motor or sensory motor or only sensory. So after this, we can conclude that probably this lady is having type 1 diabetes with peripheral polyneuropathy, sensory or predominantly sensory involvement, as there is no motor weakness or any other autonomic involvement in this case. So our job will be to assess the glycemic status by checking the HbA1c level, as well as her kidney function, thyroid function test, and most importantly, if the involvement is a bit atypical, you can go for nerve conduction study to look for whether the symptoms corroborate with the signs. Now, regarding management, optimize glycemic control. Ask the lady whether she is on basal bolus insulin, as it is a type 1 diabetes. So asking the patient whether she is getting 3 times regular insulin in the form of human actrapid and getting basal insulin in the night time. Probably the basal and the bolus combination fits the patient physiologically maximum. Other than, also ask for the glycemic control. If the glycemic control is not maintained, then you have to instruct the patient about diet and also the dose of the insulin to titrate as per the fasting, and prandial insulin sugar. And also, if the blood sugar is not well controlled, you can ask for specialist input from endocrinologist, and also offer her if the blood swing is very much there, like 400, then 80, 300, offer her that other than this basal bolus insulin regime, there is also the option for insulin pump, which will take care of her blood sugar in a better manner, but that also involves a lot of financial burden, as well as the maintenance of the insulin pump is one of the most important thing in those type of patients. Also advise the patient regarding the lifestyle. If she is very busy, then you have to ask the patient to space her diet in appropriate time, and also taking insulin regularly, not to miss any particular dose, so that the blood sugar can be controlled in a better manner, and also a regular checkup of the blood sugar at definite interval, other than cessation of smoking if she is a smoker. Other than this definitive control of the glycemic control, you have to also offer the patient the different types of medication. The first line medications is obviously the duloxetine, amitriptyline, or gabapentin. Then you have to ask the patient and educate the patient regarding food care, and if required, if there is any callosity or ulcer or anything that is not manageable in the medical ward by only controlling the blood sugar and taking care by herself, then you refer the patient to the podiatrist. Now the patient's concerns may be, I've chosen two questions. The patient may ask you, will this get worse with time, or it can be slowed, or it can be cured? The answer will be, it can be slowed with good control. It cannot be reversed totally. Can it be cured? It cannot be cured, because the damage already there is permanent, but symptoms can improve with drugs like duloxetine, and also with properly taking care of the glycemic status, it can be managed, and the complications can be delayed. Case number 2 is a 45-year-old gentleman who is a non-smoker with a history of chronic breathlessness and cough for the last 2.5 to 3 years, which is gradually progressive over time. Previously, he was labeled as a patient of chronic obstructive pulmonary disease, and advised some meter dose inhaler and bronchodilator. And in between, for exacerbations, he was given some antibiotics. The family history is her mother with a history of rheumatoid arthritis, also has interstitial lung disease. And she is now presenting for specialist opinion. Now we have to take the salient history, whether really it is a case of COPD, which he is probably stamped for a long time. Now, onset and progression of breathlessness, cough, whether it is dry versus productive, if there is any wheeze variability is there, and what is the frequency of exacerbation, what is the trigger, occupational history, exposure to biomass, smoking history. Other than smoking, if he is a passive smoker, we know about the indoor pollution, family history of lung or autoimmune disease. In this case, because his mother is having rheumatoid arthritis, so we all know there is a familial predilection for this type of involvement, and the red flag sign in the form of relatively young age, definitely. Then family history of rheumatoid arthritis with interstitial lung disease, and also you have to consider if he is having significant weight loss, anorexia, etc., etc. Now, the differential diagnosis in this patient is other than COPD, which he is already known for. He is a non-smoker, but it is not impossible because of the indoor pollution nowadays. Maybe a case of asthma with fixed obstruction, could be bronchiectasis or interstitial lung disease. Among the other things we have to consider in the lower order, like alpha-1 antitrypsin deficiency and combined pulmonary fibrosis or emphysema. But the top three diagnoses will be COPD, asthma, and interstitial lung disease, like his mother. Now, the examination should focus on general examination, like clubbing or cyanosis. Is there? You have to auscultate the chest very carefully for crackles or wheeze, signs of interstitial lung disease, if any, like fine any inspiratory capitations, crackles as classical of interstitial lung disease, rheumatoid arthritis features like joint deformities, if any. What is the oxygen saturation? You have to definitely carry this, or you may be able to find there the pulse oximetry, so you can obviously measure the oxygen saturation if it is below 92 or 90. So spirometry with reversibility is probably one of the most important parameter investigation that will make the diagnosis whether it is a case of restrictive versus obstructive lung disease. Then HRCT thorax is probably clinch the diagnosis if it is a case of interstitial lung disease. We know the different patterns of lung involvement in case of interstitial lung disease, like DPLD or other varieties, IPA, whether the fibrosis is more, whether ground glass appearance is more, like that. Then autoimmune screening, because there is family history and the patient is having lung involvement in the form of query interstitial lung disease, you have to also investigate for autoimmune nature of the disease, like rheumatoid arthritis, like ANA, etc. Other than this, alpha-1 antitrypsin level, and if the patient is hypoxic, definitely you can have one arterial blood gas, which will maybe particularly in acute situation, this ABG, though you are probably not being given any patient, will not be given any patient who is having shortness of breath, which is very severe. So always there is a stable patient. So you will be able to understand whether the ABG is required or not. Otherwise, you can at least say that I will go for EBG if it is provided for, and if the patient is having tachypnea or any form of metabolic acidosis or respiratory alkalosis. So the most likely diagnosis in this patient is interstitial lung disease, and possibly it is familial if all the features are there, like any inspiratory crackles or the clubbing is there. The patient is having shortness of breath for a long period of time, like 2 to 3 years, and it is progressive over a period of 2 to 3 years. So COPD diagnosis should be definitely in question, and you can jolly well diagnose it depending on the HRCT, if it is provided for, if the examiner tells you that there is features of interstitial fibrosis there. So you can, according to the feature, the scenario, you can formulate the plan of management. You definitely have to refer the patient to some pulmonologist and plan for vaccination. Pulmonary rehab is definitely going to help the patient, and treat comorbidities if it is there. Now, the patient concerns may be like, why do I have COPD if I have never smoked? So that is a natural question that will come naturally to the patient's and the relative's mind. But your answer will be like, while smoking is probably the most common cause, there are other causes like exposure to indoor air pollution or some genetic factors are there that can be related to COPD. Is this inherited like my mother's illness? So the answer may be like this. There is strong genetic component, both rheumatoid and certain lung conditions can run in families. And definitely there is a chance that you have probably genetically got this from your mother. Scenario 3 is a 60-year-old gentleman, long-standing. This is the last case I am going to discuss with you. The long-standing type 2 diabetes, hypertension, and known stage 4 CKD. Presented with progressive swelling, anasarca over 2 weeks, and has not passed urine in last 24 hours, that is anuria. And he feels short of breath and nauseated. The fluids, now what are the salient history points that you will look for? Shortness of breath, suggestive of fluid overload, like orthopnea, like PND, and weight gain. Uremic symptoms, if it is there, like nausea, vomiting, hiccups, pruritus, confusion because of encephalopathy, and some metallic test may be there. Diabetes control, how it is, the diabetes control is there from recent HbA1c, medication compliance, and what is the medication compliance, and like insulin, and episodes of hypoglycemia if it is there. And as you all know that this episodes of hypoglycemia is much more when the CKD progresses because of the reduction in the GFR and the accumulation of the insulin in the body. Precipitating factors may be some sort of non-steroidal anti-inflammatory agents, recent IV contrast, or sort of infections like UTI or any pneumonia. So you should always take the history of recent infections in a patient who is having this type of feature. Access assessment, ask if he has ever been told about or prepared for a arteriovenous fistula. Now the red flag sign of this patient may be, one is hypokalemia, and which can lead to complete heart block or some sort of arrhythmias leading to palpitation, or muscle weakness because of this disturbance in the potassium. Then pulmonary edema, which may be leading to severe respiratory distress at times. These are the acute red flag signs. Uremic pericarditis history, like pleuritic chest pain, relieved by sitting forward, and any history of uric encephalopathy, like confusion, seizure, or altered consciousness. End-stage renal disease is one of the differential diagnoses in this patient because the patient is having anasarca and known patient of diabetes mellitus for a long time, and also stamped as chronic kidney disease depending on his investigation, particularly the ultrasonography, which shows small kidney, and also the urine ACR is very high, 2000 or 3000 like that. So that is probably the progression of diabetic nephropathy over a period of time. Acute and chronic kidney injury is the second differential diagnosis. Acute kidney injury is often triggered by infection, we all know, dehydration, and also some sort of nephrotoxin or NSAIDs in the form of NSAIDs. Congestive heart failure, coexisting diabetic cardiomyopathy worsens renal perfusion, as you all know, which is known as the cardiorenal syndrome. And there are different types of cardiorenal syndrome. We are not going to discuss those things, and probably we will not be asked to answer those particular varieties of cardiorenal, but you have to mention in the differential diagnosis of a patient who is having features of end-stage renal disease. Then urinary tract obstruction, prostatic hypertrophy, or any bladder outlet obstruction due to any cause can cause post-renal failure. The examination, uremic fetor, pallor, or shallow complexion is one of the general findings that you can easily appreciate. Then what is the fluid status? JBP elevation is there or not? That will indicate the volume overload state, hitting edema of sacrum over the sacrum, or the legs, dependent parts, bivesicular crepitations, indicative of pulmonary edema. In the cardiovascular system examination, you always look for friction rub, pericardial friction rub to exclude pericarditis. Neurologically, if there is any asterixis or uremic flap, abdomen, palpable bladder due to bladder outlet obstruction, or palpable kidney because of polycystic kidney disease. Access, look for previous scar or non-functioning arteriovenous fistula in this type of patients. What are the investigations? We all know that electrolytes and urea creatinine, complete blood count, particularly hemoglobin, calcium, phosphorus, bicarbonate. These are the things that will help you to assess the patient's metabolic status and also the electrolyte status. Important imaging finding, definitely you will ask for ECG, which may show tall dented T waves or widened QRS because of high in potassium level, hyperkalemia, chest X-ray for pulmonary edema, like batwing opacities. Renal ultrasound will help you to assess the kidney size. In CKD, we all know, usually the kidney size is small, but in diabetes, it may not happen all the time. And also, you rule out hydronephrosis because of urinary tract obstruction or bladder outlet obstruction. How do you manage this case? You always mention about emergency stabilization in this type of patients if he is having sort of acute respiratory distress with oxygen, intravenous furosemide or nitrates, then treating hyperkalemia with calcium gluconase intravenously or insulin dextrose, immediate dialysis, initiating urgent hemodialysis via temporary central venous catheter, long-term planning, referral to the vascular surgical team for AV fistula creation and the transplant coordinator. Optimization by reviewing all nephrotoxic drugs, stopping ARB or ACE inhibitor temporarily in case of acute kidney injury, and always stop metformin because you all know that is contraindicated in ESRD. Now, do I really, the concern, patient's concerns maybe, do I really need to start dialysis today? Cannot we wait for medicine to work? Currently, your kidneys have reached a point, the answer is, your kidneys have reached a point where they can no longer clear dangerous toxins or excess water, which puts you at risk for heart and brain complication. Simple layman terms, no jargon, no medical term. We need to start dialysis now to keep you safe. Second question may be, does this mean I'll be on a machine forever? Your response may be, because this is a progression of your long-term diabetes, it is likely that your kidneys won't recover their full function. This means maintenance dialysis will be needed, but we will also discuss the possibility of a kidney transplant if you are fit for the procedure as you are young and the life expectancy is much more. Thank you so much.
If any candidates have any question, they can ask now.
Sir, can you please once again show what are the examinations we are supposed to do in this CKD patient?
Investigations?
No, sir, the examinations. What are the relevant examinations? Can you please show the list one?
Yeah. Just a minute. So these are the things. Definitely, you have to look for pallor because of, you all know that anemia of chronic kidney disease may be due to multifactorial because of the kidney problem, because of other things, general ill health, and also because of nutritional problem. Then uremic fever, this ammonia breath is there or not. Then the complexion of the patient is also one of the most important thing. There is hyperpigmentation, some shallow complexion is there. Then fluid status, if the patient is having volume overloaded state, then definitely you have to look for fluid overloaded state. You will look for JVP elevation. the dependent edema over sacrum if the patient is lying or sitting, then definitely pitting edema over the legs. And on auscultation, the bivascular capitation, lung capitation because of the fluid. The cardiovascular system, the physical friction rub. Neurological system, you have to look for uremic flap by extending the hands and looking at the hands for any flap is there. Then abdominal examination for palpable mass is there or not, lump like polycystic kidney disease or due to bladder outlet obstruction. The palpable bladder may be sometimes there. Look for previous scars and also any sort of non-functioning fistula, if any.
And sir, one more thing I want to ask. Sir, are we supposed to examine the patient in the same order which we are usually do in our routine cases? Like first we will be doing the general examination, then we will be proceeding to the systemic examination. Are we supposed to do that, or we can jumble up the thing as per the need of the case?
No, because you can do, but the time may not permit to examine like that. So definitely the most important things you have to pick up, like in the general survey, the anemia, the JBP, and pitting edema, the complexion of the patient, and definitely you can separate the general survey finding from the systemic finding, like cardiovascular, the lungs, the neurological system. But salient features you have to sum up anyway
And sir,
at one
suppose
point.
I'm suspecting that the patient is having pleural effusion. Then, sir, to evaluate,
Yeah.
examine the pleural effusion, first we have to do some inspection. Then we have to do some percussion. Then we are going to auscultation. So, are we going to do all these things? Because all these things are going to take some amount of time. Are we supposed to do all these things,
Yeah,
or
yeah.
we can just keep up
No,
the
if
percussion and
if
auscultation those parts?
no, you have to practice, definitely you have to practice again and again and again. But if there is definitely a pleural effusion that is clinically significant, you have to at least examine by doing percussion. The effusion is very high, submassive or massive, then definitely whether the trachea is deviated towards that. Usually massive or submassive may not be given. The patient will be acutely ill. Maybe you will be given a patient having pleural effusion who is very stable. So you need to at least examine him for percussion point of view, and also always auscultate the patient so that you can at least say that the breath sounds are less, or if there is any bronchial breath sounds above the effusion. Probably you have to mention that.
Okay, okay. Thank you, sir.
Yeah. Main things you cannot actually miss. Main diagnosis. If there is pleural effusion, you have to mention. If there is any mass in the abdomen, you have to mention. If the anemia is very disproportionate, then you have to mention, and also maybe you will be asked why the patient is having disproportionate anemia, or if the patient is having features of nephrotic syndrome, definitely you will be asked for to examine for, other than pitting edema, etc. What are the investigation you are going for to establish your diagnosis, other than ACR, etc. Suppose a patient is a young lady with having rash and having nephrotic syndrome. So in those cases, definitely you have to consider collagen vascular disease, young lady with rash and anasarca, and the maybe may or may not be there, maybe polyarthralgia or arthritis. So you have to consider autoimmunity, vascularitis. These are very common nowadays. So you cannot just mention about what you are seeing externally, the only the renal point of view, but also corroborate with the systemic features like rash is there, like photosensitivity is there, like your joint swelling is there, any deformity is there. So these are the things, and if the history is also suggestive that he is hypertensive, you have to mention that. So salient features you have to mention. You cannot avoid mentioning those salient features. Neither you can miss.
Okay. Okay, sir.
Like in the lady who is type 1 diabetes and having only numbness, we are always looking for other atypical presentation or any typical present other than sensory symptoms like motor weakness, if there is any motor weakness, or involvement of the bladder bowel. Incontinence is there or not. Then also history of weight loss, wasting is there or not. So these are the things that will change your diagnosis a bit, because other than sensory, you have to mention that probably the lady is having sensory motor involvement. Maybe the lady is having some difficulty while standing from sitting posture, which may be due to diabetic amyotrophy. Proximal muscle weakness may be there. So these are the atypical things and red flag signs you have maybe given, and be very careful while examining a patient. Always try to diagnose from holistically, see the patient as a whole, not just confining to a particular system, not making your vision very narrowed down. So always look for other things if it is there. It will be obvious if you are seeing the patient holistically. You will be able to diagnose. There is no confusion regarding that, no doubt about that. Okay.
Yes, sir.
Am I clear?
Yes, sir.
Okay.
Yes, sir.
These are the index cases, and the cases are given like this. We want that student should not miss very gross things, and also they have a very keen observation on the patient. Suppose a patient is having shortness of breath, any sort of swelling is there. Always examine the pulse for any atrial fibrillation irregularities. You cannot afford to miss those salient features. Okay. It happens sometimes, but these are the things you cannot afford to miss. Okay, Sana?
Yes, sir, we can have the session.
Okay. So now I'm stop sharing. Okay.
Yes, sir. Thank you all for this session, for joining this session, and it was actually a good session, sir. So, as friends, next class we'll be having on 16th January. That will be respiratory, and it will be taken by Dr. Nandini Bishwas, ma'am. Thank you, sir. Thank you all.
Thank you. Thank you so much.